Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Imagine trying to build a really highly complex ship inside a bottle, right? Using these 3-foot-long chopsticks, all while looking through a periscope.
Right. And if you make even one wrong move with those chopsticks, somebody actually bleeds.
Exactly, yeah. That is the daily reality of laparoscopic surgery. And surprisingly, the most important person in that room, the one dictating the safety and flow of the entire case, well, it isn't necessarily the primary surgeon holding the scalpel.
No, it's really not, which I think surprises a lot of people.
Yeah. So welcome to this deep dive. I'm your host, and I'm here with our resident surgical expert.
Hey, everyone. It is great to be here to dig into this one.
Today, we are talking directly to you. You know, the surgeon or doctor getting ready to step into the operating room. Our mission today is to really unpack the mechanics, the physics, and the subtle arts of being an elite laparoscopic assistant.
Because the traditional surgical hierarchy, it kind of just completely fractures when you step into minimally invasive procedures.
Oh, for sure.
The primary operator becomes entirely dependent on the person managing the visual field and the exposure.
Yeah.
I mean, if that person fails, the whole operation just grinds to a halt.
It really does. But hey, before we unpack exactly how that dynamic works, we have to state very clearly that this content is strictly for reference only.
Right, absolutely.
You must always, follow your local guidelines and hospital protocols in your own clinical practice.
Yeah, clinical protocols will always supersede general theory.
Always. So setting the stage for today's analysis, we are synthesizing a really comprehensive guide to mastering laparoscopic assistance. And the source material anchors this mastery on 3 core pillars.
Right, which are providing a perfectly stable visual field, executing smart tissue retraction, and acting as the active safety officer for the entire team.
Yeah, and digging into this whole ship-in-a-bottle scenario we mentioned, assisting in laparoscopy actually demands a complete cognitive rewiring.
It really does.
Because compared to traditional surgery right in an open laparotomy, you have direct vision, you have tactile feedback, you can literally just get your hands into the abdomen.
Yeah, you can feel the tissue.
Yeah.
But here you are, completely disconnected from that physical space.
Right.
You're forced to navigate this 3-dimensional anatomical space using indirect vision on a flat 2-dimensional monitor.
Which is a huge adjustment.
It is. I mean, your visual field is magnified, which is phenomenal for like microscopic detail, right? But it is highly restricted in scope. You lose all your peripheral vision.
You really do.
But the true cognitive hurdle, the thing that requires just intense neurological adaptation is the physics of the trocars themselves.
Oh, the fulcrum effect.
Exactly that.
Yeah.
Because the instruments, they basically pivot around fixed ports in the abdominal wall, so you're dealing with paradoxical motion.
Right. So if you want to move the tip of your grasper to the left inside the patient, your hands outside actually have to move to the right.
Right. And if you push your hands down, the tip of the instrument goes up.
It just forces the brain to constantly calculate these inverted physical vectors in real time. I mean, for a junior resident, just stepping into the role, that intense cognitive load can be overwhelming.
Well, it completely scrambles your spatial awareness at first.
Yeah.
And that intense cognitive friction is exactly why the assistant's mindset shift is the absolute foundation of the entire operation.
Right, because the primary surgeon cannot see and therefore cannot safely dissect unless your camera work and your retraction are just flawless.
Exactly. You aren't just, an extra pair of hands standing at the table. You are the surgeon's primary sensory input.
The sources just hammer this point relentlessly. A calm, anticipatory attitude beats flashy technical tricks every single time.
Every time.
The primary surgeon doesn't need an assistant trying to show off how fast they are, right? They need someone who is utterly reliable.
Because a surgeon operating with a frantic assistant is a surgeon who is actively stressed.
Oh, absolutely.
A calm assistant physically lowers the heart rate of the entire room.
Okay, let's push back on this a little bit, though, from the perspective of a real fast-paced operating room. Because the sources spend a massive amount of time on engineering the physical environment, right? Like ergonomics monitor, height, port placement.
They do, yeah.
But in practice, the circulating nurse often just kind of parks the monitor wherever the cables naturally reach. And as doctors, we often just accept it, right, to save time and get the case moving.
Right, we just want to start.
Yeah. Is taking 3 or 4 minutes to obsessively adjust a screen height really worth delaying the surgical incision?
Well, what's fascinating here is that taking that time up front directly prevents surgical degradation later in the case.
Really?
Yeah, because laparoscopy imposes a really severe static physical load on the human body.
Right.
If you accept a monitor that is positioned too high, you're forced to extend your cervical spine and shrug your shoulders for potentially hours.
Oh, wow. Yeah, that makes sense.
And that sustained isometric contraction literally starves your trapezius and levator scapulae muscles of oxygen.
Which leads to rapid lactic acid buildup and deep muscular fatigue, right?
Exactly. And when those muscles fatigue, your fine motor control completely falls apart.
Like your hands get shaky.
Yeah, the degradation is measurable. Your hands start to microtremor, and then the camera starts shaking.
And a shaking camera forces the primary surgeon to constantly readjust their own spatial mapping.
Right, which actively slows down the procedure and actually spikes the error rate.
That is wild.
So engineering the room is essentially your very first clinical intervention. The monitor needs to be directly in front of you at or slightly below eye level, so your cervical spine remains entirely neutral.
So reviewing the surgical indications dictates your port strategy before the patient even enters the anesthetic bay.
You have to.
Like a high BMI patient needing a complex pelvic dissection that demands an entirely different manipulation angle and setup than just a standard upper GI case.
Right. The geometry of the ports really dictates your mechanical advantage. The fundamental rule of triangulation requires the camera port to sit directly between the two working ports.
Okay.
You're aiming for a manipulation angle of roughly 60 degrees between the working instruments and then a 30-degree elevation angle from the abdominal wall.
So what actually happens mechanically if that manipulation angle gets too narrow, say like 20 degrees?
Well, if the angle is too narrow, the instrument shafts become almost parallel inside the abdomen.
Ah, so you end up sword fighting.
Sword fighting, exactly. You end up clashing instruments with the primary surgeon.
Which sounds incredibly frustrating.
It translates to massive torque on the patient's abdominal wall and zero precision at the working tips. You just lose all mechanical efficiency.
And poor port placement also drastically increases the risk of inadvertent tissue injury during entry rate.
Yes, it's incredibly risky.
Which is why engaging with the WHO surgical safety checklist is an active, critical part of the assistant's job. It's not just administrative overhead for the nursing staff.
Not at all.
Like confirming patient specifics, like previous laparotomies, directly informs whether you can safely establish pneumoperitoneum with a blind Verus needle, or if you need to opt for an open Hasson technique.
Right, because you want to avoid causing a catastrophic bowel injury on your initial entry. Anticipating those entry hazards really sets the safety baseline for the entire procedure.
Right, but all of that perfect room geometry and safe port placement is just completely wasted if the visual field itself is chaotic.
Oh, totally.
Which brings us to operating the surgeon's eyes. Here's where it gets really interesting. If you think of a cinematic Steadicam operator on a Hollywood movie set right, their job isn't just to point a lens.
Right.
It's to guide the viewer's eye so smoothly that the audience forgets the camera is even there. We've all seen bad drone footage that constantly pans and tilts and zooms. It literally makes you nauseous.
It does, and the clinical data supports that analogy perfectly.
Oh, really?
Yeah. Trained, disciplined camera assistants measurably improve primary operator performance.
Yeah.
A smooth, predictable visual field literally accelerates the entire case. Okay. Your absolute priorities are to keep the operative site perfectly centered and to lock in a level horizon.
Let's unpack the mechanics of that horizon, because I know it is a massive stumbling block for new assistants.
It's so hard at first.
If the horizon on the monitor tilts by even 15 degrees, the surgeon's brain has to subconsciously calculate the angle of their physical instruments to match that tilted digital screen.
Right.
It creates immense cognitive friction.
It does. And maintaining that level horizon requires strict body mechanics.
Right.
You have to hold the camera base with both hands, keeping it close to your core with relaxed elbows.
Okay.
A super common mistake assistants make is using their wrist to try and adjust the view.
Oh, yeah, like twisting their hands.
Yeah, and if you twist your wrists, you're physically torquing the heavy light cable and changing the physical angle of the lens inside the trocar.
Yeah.
That immediately disorients the horizon.
So instead of twisting your wrists, you should use the rotation dial on the camera head itself, right?
Exactly. Rotating that dial keeps the physical lens perfectly still inside the patient, while the software inside the camera head levels the horizon on the screen.
That one simple mechanical habit probably prevents hours of frustration.
Will save so much time. And furthermore, camera movement should never be abrupt.
Right.
You move the camera in these subtle arcs around the target tissue, anticipating where the surgeon's instruments are heading.
And what about zooming in?
When you need a closer view, you zoom by advancing the scope in very small, continuous, smooth steps. Drastic, rapid changes in magnification completely destroy the surgeon's depth perception.
Because the brain just cannot process the changing scale fast enough?
Exactly.
But wait, what happens when that perfect 4K view is ruined by a smudge of mesenteric fat or like a sudden puff of smoke from the diathermy? The lens cleaning protocol outlined in the sources is surprisingly rigid.
Well, it has to be rigid to maintain spatial continuity.
Okay.
When the lens inevitably hazes over, you must verbally announce coming out to clean.
Right.
You then withdraw the camera in a perfectly straight line, clean it, defog it, and return on that exact same path.
The sources emphasize this straight line withdrawal heavily. It's essentially a breadcrumb trail technique, right?
Exactly.
If you deviate even a centimeter on your way out or change your angle of entry on the way back, in your brain just loses the spatial breadcrumbs.
Yeah, get totally lost.
You might re-enter the abdomen and find yourself staring at the liver instead of the pelvis, and then the entire surgical team has temporarily lost orientation.
And finding your way back to the operative site just wastes critical time.
Right. But even if you execute the breadcrumb trail perfectly and you give the surgeon a flawless Hollywood-quality view, they still cannot safely operate if the tissue looks like a collapsed tent.
No, they can't see anything.
The camera only shows the field, but physical retraction actually creates it. Which brings us to the third and fourth hands. So what does this all mean for the tissue? How do you know if you are pulling too hard or not enough?
Well, if we connect this to the bigger picture, inadequate retraction is deeply dangerous.
Really?
Yeah, high-quality retraction applies the exact appropriate tension to expose safe anatomical planes.
Right.
If your retraction force is weak or improperly aligned, the tissue sags, that obscures critical structures. It hides vascular pedicles and forces the primary surgeon to dissect blindly.
Which is terrifying.
Yeah.
Let's map out those physical vectors then. If we are assisting on a laparoscopic cholecystectomy, for instance, you don't just grab the gallbladder and pull randomly.
No, definitely not.
The mechanics rely on pulling along the axis of the organ's natural anatomical attachments.
Right.
You retract the fundus cephalid, towards the head and laterally over the liver. Why is that specific vector so critical?
Because that specific lateral encephalid vector of tension actually opens callus triangle without tenting the common bile duct.
Yeah.
Tenting occurs when you pull too hard or in the wrong direction, and you physically drag the main bile duct up into the surgical field.
Making it look visually identical to the cystic duct.
Exactly. And if the surgeon fires a clip across that and cuts it, it is a devastating, life-altering biliary injury for the patient.
Oh, wow.
So you must use steady, low-amplitude force to prevent that anatomical distortion.
You sort of hold the tension steady like a taut sail.
Yes.
Absolutely no sudden yanking or jerky sawing motions, right? Because that fatigues your own hands and causes micro tears in the delicate serosa of the organ.
Right. And beyond managing tissue tension, there is a golden rule of intraoperative safety that just cannot be compromised.
What's that?
Never under any circumstances let your instrument tips drift off screen.
It's basically like driving a car at high speed while only looking through a highly zoomed-in backup camera.
That is a perfect way to describe it.
If the front bumper, which is your instrument tip, isn't visible on the screen, you have absolutely zero spatial awareness of what you're about to run over.
Zero.
An instrument hovering blindly in the abdomen can puncture a bowel loop or tear a mesenteric vessel without anyone noticing until it becomes a massive crisis.
And that lack of spatial awareness extends directly to energy safety as well.
Right, the cautery.
When the primary surgeon activates monopolar cautery, your job is to keep your non-active metal instruments far away from their active tip to prevent electrical arcsing or direct coupling.
Wow, so you are simultaneously scanning the background of the image to verify no stray bowel or omentum is hidden directly behind the structure being cauterized.
Exactly. You're watching closely for unexpected charring or thermal spread.
You really are the active safety officer monitoring the entire field.
You have to be.
But let's present a worst-case scenario. Say a major vessel pops. Suddenly, the pristine visual field is just a sea of red.
Right.
The natural human instinct is to panic grab the suction irrigator and start aggressively jabbing suction tip around the pool of blood trying to find the source.
Which is the worst thing you could do. That behavioral response will almost certainly worsen the injury, potentially tearing the vessel further.
So what's the right move?
During acute hemorrhage, Your priority as an assistant is calm, targeted suction to clear the visual field while simultaneously centering the camera on the bleeding point.
Okay.
You do not work blindly in a pool of blood. You systematically clear the view so the primary surgeon can identify the precise vascular defect and safely apply a clip or suture.
So calmness under fire basically stabilizes the physiology of the entire room.
It absolutely does.
So mastering those physical tools, right, the camera mechanics, the retraction vectors, the suction protocols that gets you to the table, that is the baseline.
Yeah, that's day one.
But the final leap to becoming a truly elite assistant seems to be about mastering time itself, moving from simply reacting to what the surgeon is doing to actually predicting their next 3 moves.
The anticipation game.
Right, guys.
This is what elevates a competent assistant to an indispensable one. And this raises an important question. You don't magically develop this sixth sense, right? You construct it.
Right, but how exactly do you develop this sixth sense of anticipation without overstepping your role or just cluttering the OR with unnecessary chatter?
Well, it's about intense situational awareness and incredibly disciplined communication.
Meaning speaking less, but delivering far higher quality information.
Exactly. You use short, highly precise, standardized phrases, like camera coming closer or smoke in field clearing, or your hook is near the clip.
Okay.
It keeps the operative team perfectly synchronized without cluttering the cognitive space with noise.
That makes total sense.
Furthermore, your situational awareness must penetrate beyond the surgical monitors.
It's like listening to the anesthetics team.
Yes. Are they reporting rising end tidal CO2 levels, indicating an issue with the pneumoperitoneum? Is the patient becoming unexpectedly hypotensive?
You should be tuned into the scrub nurse too, right?
Yeah.
To catch instrument or swab count discrepancies the moment they happen rather than waiting till the end of the case.
Exactly. You are monitoring the telemetry of the entire operating theater ecosystem.
And crucially, the elite assistant's job doesn't end when the trocars are pulled from the abdomen. The post-operative loop is where the real acceleration in surgical skill happens, right?
Absolutely.
You stay actively engaged through the sign-out and the specimen labeling, which is, again, a vital WHO checklist step to prevent retained items or catastrophic misdiagnoses.
Right.
But then you deliberately ask the surgeon for feedback.
Requesting 2 to 3 minutes of specific targeted feedback on your camera work and retraction right after the case is invaluable.
What should you ask them?
Ask them things like, did I maintain the horizon effectively during the pelvic dissection? Or was the tension on Cowlett's triangle adequate? Or did I tenth the duct?
And then you take that feedback into mental replay.
Yes.
Whether you're charting back on the ward or commuting home, you mentally sequence the operation. Where were the ports placed? How was the exposure achieved? Where did you lose orientation during that breadcrumb trail?
Right. You replay the tape.
Just like an elite athlete reviewing game footage, actively turning those physical repetitions into permanent mental pathways.
And that deliberate reflective practice is exactly how you transition from being just an assistant to a deeply trusted co-surgeon.
Wow.
And ultimately, it's how you prepare the neurological pathways to become a confident primary operator yourself.
So to recap this incredible journey, assisting in laparoscopy is just an immensely challenging, physically demanding, and intellectually rigorous role.
It really is.
You are managing the inverted physics of the trocars, the biomechanical geometry of the room, the absolute clarity of the vision, the precise tension of the delicate tissue, and the safety signals of the entire OR ecosystem.
It's a lot. And if we consider all of these compounding responsibilities, it leaves us with a fascinating final thought to ponder, really.
Oh, what's that?
Well, if you, the assistant, are the one controlling the field of vision, generating the critical tissue exposure, and monitoring the safety threshold of the entire room, might it actually be the assistant and not the primary surgeon who is quietly setting the true pace and rhythm of the entire operation?
Oh, wow. Building the ship in the bottle, but you're the one holding the flashlight, the tweezers, and the blueprints.
Exactly.
It completely flips the script on traditional surgical hierarchy.
Sure does.
To you listening right now, if you liked this content, do not forget to share it with at least one of your colleagues or friends to spread the word.
Highly recommend it.
Send it to your favorite scrub nurse, your junior residents, or your attending. Also, check out our YouTube and other social media pages.
Lots of great stuff there.
And do check our previous season and episodes, which feature some very relevant topics to keep sharpening your clinical edge. Until next time, keep your horizon level and your instruments on screen.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe.
Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.